How to help. Hello, and welcome to the next lecture of our course. Today, we'll explore how physiotherapists can extend support to victims beyond identifying them during treatment. We'll focus on providing information and making efficient referrals to specialized support services, fostering a multi-agency response. The goal of this lecture is to enhance your ability to respond to patients' disclosures of abuse and guide them to appropriate services. In a multi-agency context, there are established human rights standards, laws, policies, and effective strategies for addressing DV or IPV cases. Building a trusting, respectful, gender-sensitive, and culturally appropriate relationship with the victim lays a solid foundation for helping them in navigating the system and seeking specialized support. UN Women has developed a multi-sectoral response model that requires holistic inter-organizational and interagency efforts. It promotes victim participation, interdisciplinary cooperation, and coordination across sectors such as health, psychosocial support, legal or justice, and security. The Istanbul Convention stands as a significant and legally binding international agreement that has bolstered integrated policies and multi-agency work in support of DV and IPV victims. Specifically relevant to this lecture are the following articles. Article 15, Training of Professionals. Parties must provide or strengthen appropriate training for professionals dealing with victims or perpetrators of violence covered by the scope of this convention. This includes training on prevention and detection of such violence, gender equality, victim needs and rights, and prevention of secondary victimization. Training should encompass coordinated multi-agency cooperation to ensure comprehensive and appropriate handling of referrals in cases of violence under this convention. Article 21, Assistance in individual or collective complaints. Parties must ensure that victims have access to information and applicable regional or international individual or collective complaints mechanisms. They should also facilitate sensitive and knowledgeable assistance to victims in presenting such complaints. Article 22, Specialist Support Services. Parties must enact legislative or other measures to provide or arrange immediate, short, and long-term specialist support services in adequate geographical distribution to victims of violence under this convention. They must ensure the provision of specialist women's support services to all women victims of violence and their children. Health professionals' responsibilities. There is a critical link between the consequences of DV and IPV and response services. Health professionals play a crucial role in the chain of response services, offering support to mitigate harmful outcomes and prevent further injury, trauma, and harm. Response actions should include assisting or supporting the victim, providing appropriate consequences to the perpetrator, and restoring or maintaining security for the survivor and the community. Let's do a little exercise and think what types of assistance a survivor might require to mitigate the harmful consequences of violence. These can be categorized into health, psychosocial, security, and legal justice. Assistance may include, in the health category, treating injuries, managing sexually transmitted infections, offering emergency contraception services, and addressing mental health concerns. Moving to the psychosocial category, providing emotional support and counseling, offering financial support and income generation programs, conducting skill training programs, and facilitating group counseling. Within the security category, reporting to police, investigating cases, making arrests, and filing charges. And within the legal justice category, applying appropriate laws and holding perpetrators accountable. It's essential to note that the legal justice can be formal, informal, or traditional. Formal legal justice refers to the established legal systems recognized by governments, characterized by codified laws, official institutions, and formal procedures. Informal legal justice encompasses community-based dispute resolution outside formal legal structures. Traditional legal justice relies on indigenous or customary practices rooted in cultural contexts. These categories are not mutually exclusive, and legal systems may incorporate elements from each based on cultural, social, and historical factors. To initiate high-quality, multi-sectoral, interagency response services, victims, especially those within vulnerable and marginalized groups, must first report incidents of DV or IPV. Subsequently, victim support requires a gender-sensitive and culturally appropriate holistic response, extending beyond physiotherapy or health sectors to incorporate assistance from service providers in health, psychosocial, security, and legal justice fields. The National Institute for Health and Care Excellence, or NICE, in the UK, has formulated guidelines for training healthcare professionals. Your role should align with the level of training you've received, enabling you to deliver either a universal or specialist response as follows. Universal. Level 1. Able to respond to disclosures sensitively and direct individuals to specialist services. Level 2. Capable of conducting routine inquiries, assessing safety risks, and referring individuals to specialist DV services. Specialist. Level 3. Competent in identifying and assessing risk, developing safety plans, and collaborating with women's specialist services and other specialized units or services. Level 4. Proficient in providing expert advice and support to women and individuals experiencing DV. No matter the level of your role, you should have available the necessary information on the referral pathway in your community, how to access specialist advice for safeguarding children and vulnerable adults, whether you work in a comprehensive healthcare setting or you work independently, protocols for sharing information when you are making a referral, or if you are asked to contribute information by an external agency. The NICE guideline recommends that trainers offer 4 levels of training to equip health professionals to respond effectively. Trainers should also raise awareness among managerial staff and empower them to support professionals efficiently. With adequate training and confidence, practitioners can provide more effective support to victims of any age, focusing on their professional responsibilities, utilizing local integrated care pathways, early identification, assessment, interventions, short-term coping and long-term recovery, gathering and recording information, and maintaining confidentiality while sharing information. Responding to victims, risk assessment and safety planning. Ensuring the safety of patients who have experienced DV is paramount in any health sector intervention for gender-based violence, or GBV. This typically involves a pattern of repetitive coercive control, and separation often heightens the risk of violence. Most murders, attempted murders, and serious violence occur when a survivor attempts to leave a violent partner. As a health professional, you play a crucial role in providing referrals to a GBV advocate or specialized support services, which can assist victims in risk assessment and safety planning. In general, the more risk factors present in a specific case, the greater the risk of repeated or escalated violence. These risk factors include previous acts of violence against the woman, children, or other family members, including former partners, which can be assessed through potential histories of abuse and patterns of violence recorded in medical records. Previous acts of violence outside the family, indicating a general tendency toward violence in the home. Times of separation and divorce, which are associated with heightened risk. Acts of violence committed by other family members of the perpetrator, which can be used to control the survivor. Possession and/or use of weapons, legally or illegally, increasing the risk of armed violence. Abuse of alcohol or drugs, which may contribute to an escalation of violence. Serious threats, particularly those of murder, which must always be taken seriously as they often precede severe violence. Extreme jealousy and possessiveness, indicative of a desire to control the partner. Patriarchal attitudes and concepts, such as rigid ideas about honor and sexuality, which can perpetuate violence. Persecution and psychological terror, including stalking, aimed at preventing separation. Risk to children, who may also be targeted by the abuser during separation and divorce. Non-compliance with restraining orders, indicating a high-risk situation. Possible triggers for sudden escalation, such as changes in the relationship or seeking help. Safety planning must always consider the safety of both the survivor and any children involved, and health professionals must be vigilant in assessing and responding to these risk factors to ensure the well-being of their patients. Undertaking a risk assessment. Risk assessment enables criminal justice authorities to decide on actions against the perpetrator. It also enables health professionals and other service providers to support the patient in identifying measures to increase their safety and to raise their awareness of the risk. You may find acronyms useful to memorize key factors or steps in assessing risks. A commonly used example in the UK is SPECSS+, which stands for S. Separation and child contact. Leaving a violent partner is extremely risky. P. Pregnancy. Pre-birth to under 1 year old. 30% of DV and abuse starts in pregnancy. E. Escalation of violence. Previous DV and IPV is the most effective indicator that further DV will occur. 35% of households have a second incident within 5 weeks of the first. C. Cultural factors, such as language barriers, immigration status, and isolation. S. Stalking. Research finds that intimate relationship stalkers use more dangerous stalking behaviors than non-intimate relationship stalkers. S. Sexual assault. Where abusers use both physical and sexual violence, victims are at an elevated risk. Additional current risk factors that stand for the plus in the acronym may include suicidal thoughts, homicidal thoughts, threats to kill your patient or other family members, abuses family pet, access to weapons, alcohol or drug use, and a history of assault. A rapid risk assessment can be conducted with just 4 questions. Is it safe for you to go home? What are you afraid might happen? What has the abuser threatened? What about threats to the children? Support your patient in developing a safety plan. Safety planning is a vital aspect of risk management, aiming to prevent violence by addressing risk factors and leveraging protective factors. It focuses on enhancing the survivor's resources, both dynamic, like social support, and static, such as physical security measures like locks or cameras. Safety planning is especially crucial for those intending to leave abusive relationships, providing pathways to further support for women experiencing violence. However, developing a safety plan can be challenging, particularly for low-income women, especially those from rural or ethnic minority communities. They may lack the resources to leave the abuser and may not have access to shelters or temporary accommodations. In immediate danger and without shelters, health facilities might offer short-term stays. Typically, support services like women's shelters or organizations are experts in assisting victims. We'll introduce a checklist to guide you in developing a safety plan with the patient. You can find it on Moodle, along with examples of how to fill it out. Checklist for developing a safety plan with a survivor of violence. Identify a trustworthy neighbor who can help if there's trouble. Have trusted friends or relatives who can shelter you and your children for a few days. Plan where to go if you need to leave home unexpectedly. If an argument is inevitable, choose a room with an easy exit and no access to weapons. Practice how to leave your home safely. Keep a bag packed with essentials at a relative's or a friend's home. Establish a code word for emergency help. Trust your instincts. If it's dangerous, consider complying to calm the situation. Remember, you don't deserve abuse or threats. Referral pathways. Physiotherapists may often serve as the initial point of contact for DV or IPV victims, positioning them to refer individuals to crucial support services. This might entail directing them to other healthcare professionals, such as mental health providers, or connecting them with organizations offering psychosocial or legal assistance. Across the European Union and globally, GBV advocates and organizations are dedicated to combating DV and IPV, raising awareness, and providing resources. The No More Global Directory, for instance, offers a wide array of domestic and sexual violence helplines and support services worldwide. While these advocacy groups vary in name and structure, they share a common mission: addressing GBV and advocating for gender equality. Typically, they collaborate with government agencies, law enforcement, healthcare providers, and others to comprehensively tackle the issue. Given the multifaceted needs of DV and IPV survivors, an effective response demands a comprehensive range of services. Since no single organization can provide all necessary services alone, a multi-sectoral approach involving various service providers is essential to ensure comprehensive support. Establishing effective referrals hinges on having an institutionalized care pathway. This often involves collaboration among government departments, women's organizations, medical facilities, and more. Referral mechanisms may operate at national, regional, or local levels, adhering to national laws and policies. For physiotherapists, effective referrals entail several key aspects: recognizing and facilitating disclosure of DV and IPV and offering initial support, assessing the individual's situation and needs, with high-risk cases requiring immediate crisis intervention, understanding national GBV laws, including reporting obligations, obtaining consent before sharing information, except in emergency situations where safety is at risk. Developing a referral pathway goes beyond establishing a system. It requires commitment, partnership, and awareness of available support networks, protocols, and trainings. Programs like IRIS, Identification and Referral to Improve Safety, in the UK, focuses on training healthcare professionals to identify and respond to domestic violence and abuse effectively, leading to significant increases in identification rates by doctors in general practice. Specialized women's support services. In a multi-sectoral response to DV and IPV, women's support services play a crucial role. These organizations, with their extensive experience in addressing GBV, provide specialized assistance and accompany survivors throughout the entire process, complementing the general support services offered by public authorities. Specialized women's support services for DV or IPV encompass a wide range of resources, including women's shelters, helplines, and counseling centers. These organizations may cater to survivors of GBV in general or focus on specific forms of violence, such as IPV, trafficking, female genital mutilation, or sexual violence, or particular groups, such as migrant and refugee women, adolescent girls, or women in prostitution. These services are integral to the referral pathway and serve as valuable assets for physiotherapists and other healthcare professionals. Staff members are trained to understand GBV, offer critical support, and collaborate with law enforcement when necessary. Women's helplines. Helplines serve as the initial point of contact for survivors, offering information about available services and legal options, crisis interventions, and referrals to face-to-face support services like shelters or the police. Operating 24/7, these helplines are free, anonymous, and accessible to all women in the country, typically available in multiple languages. Women's shelters. These shelters provide immediate and secure accommodation for women survivors and their children, along with comprehensive support and empowerment programs to help them cope with their trauma, rebuild self-esteem, and pursue self-determined lives. Safety measures include risk assessment, confidentiality, and security protocols to safeguard clients, staff, and neighbors from potential violence. Women's centers. Also known as women's crisis centers or counseling centers, these facilities offer non-residential support services such as counseling, legal assistance, practical support, and court accompaniment. They are particularly vital in areas where women's shelters are unavailable, providing advocacy and counseling to women in need. Sexual assault support centers. These specialized services cater to survivors of sexual violence, offering immediate medical care, trauma support, psychological counseling, and forensic examinations for evidence collection. Staff members are highly trained to provide sensitive and comprehensive care tailored to the needs of survivors. General Support Services. General Support Services, funded and provided by public authorities, offer long-term assistance not exclusively tailored to survivors, but benefiting the general public. These encompass health services, housing, financial support, social services, employment assistance, public education, and child welfare. These services complement specialized support services and often serve as the initial point of contact for victims and survivors of DV and IPV. The police and criminal justice system are responsible for investigating and prosecuting cases of DV and IPV, and other forms of GBV that constitute criminal offenses under national laws. They also play a role in separating perpetrators from victims and survivors. In some countries, police have the authority to issue and enforce restraining orders, while in others, civil courts issue protection orders. Multi-agency cooperation. Women survivors often turn to healthcare services such as hospitals, doctors, physiotherapists, or other healthcare providers more frequently than any other support service. However, it's essential not to limit assistance to health providers alone. Collaboration between the healthcare sector and specialized women's support services is crucial to ensure that survivors receive comprehensive help after experiencing violence. Many victims feel ashamed or embarrassed, which may deter them from seeking help from other organizations. Effective multi-sectoral cooperation between the health sector and specialized women's support services can combat victim blaming and self-blame, facilitating access to support services and increasing awareness of available resources in the community. Coordination of services and multi-agency cooperation are obligations deriving from the Istanbul Convention, the legally binding instrument aimed at preventing and eradicating violence against women and domestic violence. There are 8 stages of multi-agency cooperation. Establish a shared philosophy of cooperation with principles and goals focusing on victim safety, perpetrator accountability, and avoiding victim blame. Develop agreed procedures with sensitivity to the victim's experiences. Monitor and track cases to ensure accountability, clarifying the roles of each professional group. Coordinate the exchange of information among professionals, fostering mutual understanding of confidentiality rules. Provide resources and services for victims and survivors. Ensure sanctions, restrictions, and services for perpetrators. Develop actions to prevent harm to children and provide therapy for their traumatic experiences. Provide ongoing training for professionals involved in the cooperation. That concludes today's lecture. Thank you for watching. In the final lecture of this course, we will discuss the main challenges that arise from helping victims of violence. Don't forget to complete your homework, and I look forward to seeing you in the next lecture. Goodbye.